right, good evening, everybody. We have just over 200 people on right now. Probably many more will be joining as we get going. But just to be respectful of everybody's time, we'll get started. So I want to welcome everybody this evening to the AO Trauma North America webinar on distal femurs, to nail, plate, or both. As we go through this, just a reminder, if you have any questions or comments, please use the Q&A panel. Our wonderful panelists will be taking a look and answering them in some way, shape, or form. If we do not get to your questions, we apologize, but we will do our best to answer as many as possible. I want to thank and welcome our panelists, John Scalero from UC Irvine, Matt Garner from Penn State Hershey, and myself from Philadelphia University of Pennsylvania. And so with that, we will get going. These are our conflicts of interest, nothing really relevant to what we're doing or what we're looking at this evening. So some learning objectives. So at the end of the session, we're going to be able to discuss optimal fixation constructs for distal femur fractures, understand some clinical indications for plating, nailing, and combined fixation constructs, and then develop a little bit of a stepwise approach for nail plate combinations. So the session is going to look something like this. Matt put his hard hat on for this, and we're just going to go over a brief intro of the problems. We're going to mostly focus on cases. I think we have a nice group of cases here to discuss some of the points. A little technical trick at the end, and then we'll wrap up. So without further ado, we'll jump into it. So distal femur fractures, as a lot of us know, they happen, and it's not that insignificant. Most of us will take care of them in some way, shape, or form at our institutions. The mechanism, just like almost any injury to lower extremity, similar to the hips, younger, it's high energy mechanism. Older, it's more of a lower energy osteoporotic type of fracture. And the management of these can be challenging for multiple different reasons. Some of the challenges that have been described in the literature and that we know of just by treating these is that there's often metaphyseal comminution. There's often, short articular segment, which makes it difficult to get fixation. The bone quality around the distal femur, especially in the elderly and periprosthetic fractures, can be really poor and really difficult to achieve optimal fixation. And then there's often a mismatch between the anatomic and mechanical axis of the femur, which makes it quite difficult and challenging to take care of these. And additionally, in these elderly low energy injuries, the morbidity and mortality have been reported to be similar to geriatric hip fractures. So it's important to get to these in a timely fashion and to get them moving as best we can. Again, there's poor bone quality. Oftentimes we're working around other implants. They're around either above total knees, below total hips, or in between a couple of different prostheses, which can make it challenging. And then in these elderly patients, we need to be able to mobilize them and get them moving. And so if we can give them a construct to get them walking on it as soon as possible, then it's ideal. Goals of treatment, just like anything else, for the articular injury, if there is one and there's not a joint that's replacing it, is to get an anatomic reduction and an absolute stable construct for articular fragments. For the shaft and for the limb itself, we want to restore length, alignment, rotation, make sure we're getting that right so the joint below and above are lining up appropriately, that we get stable fixation, allow for early range of motion, and possibly early weight bearing as possible. So how do we do this? So we have multiple different fixation options and then other surgical options. We have traditional single implant options with our, distal lateral femoral locking plates, our retrograde intramedullary nails. We have, which has been popularized more recently, the idea of combined constructs with dual plates or nail plate combinations. And then from an arthroplasty perspective, the idea of an acute arthroplasty in the form of a distal femoral replacement or some kind of revision style knee replacement, which we really won't be talking too much about here tonight. And now with the traditional fixation constructs, although, with newer implant designs, we've gotten a little bit better at this and our success has been better. It's still a significant rate of malunion and non-union, even fixation failure. And so the idea of these combined constructs have started to become a little bit more popularized, especially in the use of poor bone or in a setting of non-unions. There's emerging literature coming out in regards to this with the proposed benefit of potentially early or immediate weight bearing thereafter. So with that, we're going to jump right in to kind of the cases and spend the majority of time looking through those. So Matt and John, feel free to unmute yourself for this part and we'll get going here. So this is our first case. So this is a 17-year-old male who was involved in an MVC and came into the hospital with this distal femur injury. John, when you first see this person, what's starting to go through your mind?
Closed injury, I'm assuming.
Closed injury.
Yeah. So I, want to just make sure I get a, good idea of what the articular involvement is, and then starting to look kind of immediately at what my reads will be. Not only for the, be able to do an open reduction, most likely for the articular portion, but looking at the metaphyseal reads. This is a shorter segment distally, and so I'm trying to see if I have something on the medial or lateral side that's going to be a nice key in that will allow me to set the distal block onto the shaft. And so probably looking to get a CT scan, and then for me just kind of moving along. And I think that here, do you want to get into exactly what I'm thinking about in terms of implants right away, or?
Not yet. Let's take a look at the CT scan, the cuts that we have. So some of the axials. Take a look at that for a second. And then some of the metaphyseal. Yes, go ahead, John.
Yeah, there's a lot of metaphyseal comminution, but the actual joint itself doesn't look too complex. It looks like a pretty simple articular, two articular pieces.
Yeah, good. So with this, we'll launch our first polling question, and then I'll get back to you, John, in regards to your thoughts of how you would approach this and how you would treat this. So for the audience, so how are you going to approach this injury? Are you going to do a direct lateral subvastus? Are you going to do an arthrotomy, either lateral or medial? Are you going to do a medial subvastus, or I guess some combination thereof? So we can launch that and see where you take it. So if you're watching, click on what you would do to approach this injury. Great. So so most people, look like 64% or so, chose a lateral parapatellar arthrotomy. So Mark, we can close that out right now. And so John, I'm just going to click back to the CT scan so you can take a look-see at it. And what are your thoughts? How are you going to approach this? And tell me what you're thinking from a fixation perspective.
Yeah. So, I think the workhorse for any of these articular injuries for me is some sort of, lateral parapatellar, depending if oftentimes is open, if there's an open wound and it's the soft tissue wound itself is directly anterior, I'll use an anterior skin incision, and then continue that on to more of a lateral parapatellar and elevate the lateralis. I think one of the things, for me, if I'm thinking about dual approaches, I want to make sure that if I'm going to the medial side, that's going to be, the reason I'm doing that is because there's a read there that I may not have on the lateral side. And so looks like there's metaphyseal impaction. There's a cortical piece that's on the medial side there. It looks like I believe on the top images that's on the medial side, that cortical fragment. So if I'm going to go over to the medial side and disrupt the biology there, I want to make sure that it's for a reason, and that's a read that I'm not going to have on the lateral side. If not, I can probably utilize just some sort of lateral parapatellar for the whole injury.
Great. So how are you going to fix this? What's your implant choice?
Yeah. So for me, this is going to be independent lag screws across the joint involvement, and usually use a 3.5 millimeter, just small fragment type screws, and then a laterally based plate. And then again, in a healthy patient, a good healthy patient with without any other reasons for poor bone quality or comorbidities, I think just a lateral implant alone would be my go-to in this one.
Yeah, so I don't think too dissimilarly from you, John. Matt, why don't you walk us through kind of your thought process here and your sequence of fixation and why you chose what to do?
Yeah, so obviously, I mean, this was my case. Clearly, I had the same exact thought pattern that John had. I mean, lateral parapatellar, get the articular surface. You can see in the top left, you don't see my articular clamp, but the wires are there holding the articular block in place. That free kind of anterior lateral fragment you can see in the top right image has kind of anterior to posterior screws in it. The struggle that I had with this case, and one that I've run into in the past, especially in young people with metaphyseal impaction like this one, was getting the rotation correct, because I didn't have a good lateral cortical read. I thought I would. And once I got there, you can see that top central fragment, that bone, he was 17, but relatively immature 17, and maybe that had something to do with it. There was almost some plastic deformation there, and I couldn't get a good read, so my rotation was off. And the more I looked at it, the better read I had on the medial side. So I opened there, got a good reduction, point reduction clamp there, modified straight, and a really good anti-glide plate, just a simple reconstruction plate there to kind of lock in the rotation. And then everything kind of fell together from there. I teach, I have residents, I have fellows. I try to use non-locking plates when possible, when it's appropriate in a 17-year-old with fantastic bone. Large fragment proximal tibia plates fit very well in the distal femur, so that's what we used on the lateral side. There was nothing to that other than I didn't think it needed a locking plate, but that certainly would be the go-to in anyone else. So same exact sequence you discussed: clamp the joint, lag screws across the joint, fix the articular block. There was a free fragment anterior laterally, and then put the articular block back to the shaft. And for me, in this case, I had a medial read, so I opened both sides.
Yeah, I like that as well. I mean, that's a good, good example. And I think a top left image there, Matt, shows that really nicely. You can see the amount of comminution and kind of the impaction, the metaphysis, and you can see that void that appears in that what you didn't really have on the lateral side. It can be tough to dial in the condyles to a shaft that almost looks like a nubbin.
Yeah, there was a question that just popped up on why not a locking plate with non-locking screws, and there's nothing wrong with that either. I think you could literally use almost anything in this situation. The condylar plates, the prefabricated, pre-contoured condylar plates are fantastic, and I mean 99 out of 100 times I would do that. This situation, we went with something different. That's all.
But I think the principles, though, Matt, are similar, right? And so I think that's important. So from what I'm hearing, why you decided to use two plates here is you felt you had a better read on that medial side, which was going to allow you to build your articular segment and that read back to your metaphysis. So that was your decision. So what did you do for this person post-operatively? How do you manage this person in the post-op period from a weight-bearing perspective to range of motion? What do you do?
Yeah, so a lot of that depends on the patient. This patient had a metaphyseal defect due to impaction. He's 17 and healthy, so I made him non-weight bearing, no bracing, immediate range of motion. Usually give him a day or two to let the soft tissues calm down, but try to get motion back pretty quickly. Older patients, I do everything possible to try to get them weight bearing immediately for all the reasons you talked about earlier. But when they're able to tolerate limited weight bearing, I typically do 30 pound foot flat weight bearing for balance, or weight of leg weight bearing for balance. I try not to make people completely non-weight bearing because they tend to get off balance when they're hopping around. but then again, it really depends on what other injuries they have. This was an isolated injury, I believe. So 30-pound foot flat weight bearing, range of motion immediately.
Great. And then the consideration just popped up real quick. I think it's important we can touch on it now, and it'll come up a little bit later as well. The idea of doing multiple incisions around the knee and kind of skin bridges and things of that nature, is that a consideration when you're doing this?
Yeah, absolutely. I mean, that 7 centimeters or 9 centimeters, that comes from knee literature. So I think it's important to pay attention to that. If you talk to your microvascular surgeons and your plastic surgeons, far more important than the distance between the incisions is the overlap of the incisions. It's really hard not to have a lot of overlap in the distal femur. So these incisions tend to overlap quite a bit. So I do try to keep it at 7 centimeters. So if I'm considering going medial, I may cheat my my lateral parapatellar a little bit more lateral because I have a little more flexibility with that. But you can also make your medial a little bit more posterior than typical as well.
Great, thanks. And then one last question, move on next case for time's sake. Why'd you take the hardware out?
He was 17 and he thought it was bothering him. He asked for it. For me, you really have to ask to get your implants taken out. He also had that little spur on his distal femur that you can see in those central images. I'm not entirely sure if that was translation or where that articular impaction fragment was with the front to back screw. So I burred that down too while I was there. I think it was causing a little bit of symptomatic patellar clunk. So the combination of reasons I took it out. I usually do not.
Gotcha. All right, great. For sake of time, we're going to move on to the next case. John, anything to add before we move on?
No, I like it. Good case.
There was a question real quick while you're switching over about graft. I don't think, most of us don't graft acutely. I would try to avoid grafting acutely unless you needed to. If there's a big defect, come back in 6 to 8 weeks or so.
Great, thanks, Matt. All right, so 87-year-old twisting injury. John, maybe like a very high level view. What are you thinking here?
Just what's going to allow me to weight bear this patient immediately and allow them to mobilize, and then for bone quality and making sure that I don't leave a stress riser or an area that is uncovered. This is a protect the entire femur one way or another.
Great. Yeah, I agree. Definitely thinking about that and how to mobilize this person. So we'll launch the next poll question. So how are we going to do that? So, how are we going to fix this fracture? What's our preferred fixation construct? Absolute stable construct, relative stable, some kind of hybrid, doesn't really matter as long as we're protecting them. Great. So interesting. So, kind of mix across the board. So 40% for absolute, 32% for relative stability, 24% for a hybrid construct, 3% for doesn't matter. So we can close that out. And then, Matt, so this is our floor shot, and I'm going to go to your finals here. Walk us through your thought process. What you try to achieve.
Picking on me again. So I think there are a number of different ways to fix this. I completely agree with John. Whatever's going to get them weight bearing immediately. I think a good anatomic reduction, interfragmentary fixation, compression. You get a lot of friction interference fit that can allow you to weight bear. I see a long spiral oblique in an interprosthetic fracture, and the first thing I think of is anatomic reduction and an anaglide plate. So that posterior lateral plate is an anaglide plate, a buttress plate, whatever you want to call it, but at the posterior lateral extent of that oblique fracture, which I think gives you a tremendous amount of stability. Dave Helfig calls that a plate as a clamp. So you use that for your preliminary reduction and you lag through it. And then your lateral condylar plate is a little more robust, but serves as primarily a neutralization plate. I let them weight bear immediately. I will admit that it's a relatively extensile approach. I usually don't make the incision all the way to the trochanter, but you certainly need to see the fracture to get it reduced. I allow them to weight bear immediately on this construct, and I've been luckily pretty successful with that. I may regret it someday, but I haven't yet.
I think it's a nice looking construct. I like the idea of absolute stable construct here when you can, and then overlap of the prosthesis, like John said earlier. John, what would you have done differently, if anything?
I don't think anything. I like this. I just going back to the initial question that you had posed, in poor bone quality like this, I mean, the lag screws function to help you achieve reduction in order to place the most, the next dominant implant. I don't know that they're, I mean, this is every time that we see lag screws like this, we see the final images like we do on the right hand side, where we end up getting a little bit of callus, because honestly, by the time that they move the patient, to the gurney and then back over to the recovery room, those, I guarantee you, those lag screws have already started to shake a little bit. So, the purpose of that plate as a clamp, and the purpose of the lag screws is really just to set yourself up for the more dominant implant. And I think there is something to having a nice reduction, so that you're not relying on the implant to do all the work. Once you have apposition of the fracture surfaces, that can help a lot. And then one of the things that oftentimes comes up is people are knee jerk going to cerclage cables the minute that they have to get around other implants. And I think there's been biomechanical studies that have shown the importance of utilizing screws instead of cables when possible. And almost all of these implants now, especially ones that have options for kind of multi-directional screws, or use of small fragment screws, you can get an anterior or posterior to most of the hip stems. And if I see cement, that's even better, because that's like great bone quality in my mind. So utilizing screws when possible to get around implants like it was done here.
Yeah, I think that's great. I'm always disappointed with my lag screws in this type of scenario with poor bone quality as well. Matt, one of the questions that popped up, which I think is a really important one to talk about, where is the ideal location for your laterally based plate to prevent deformity?
Yeah, so I'll try to answer two of the questions as we go through it. One of the other questions was positioning. So I think being in a position to get really good orthogonal X-rays is important for plate placement. So you need to be able to get a perfect lateral and the best AP possible. I tend to do a little bit of a sloppy lateral, a bump. That way I can rotate the leg almost into a full lateral position or a full supine position. The optimal placement really depends on the implant that you choose, and there's a number out there. Some have a little bit more flexibility than others. The one in this image probably has the least flexibility. I try to get it as anterior as possible. You really want it to be on that anterior lateral obliquity of the trapezoidal nature of the distal femur, and really try to stay off of the primary aspect of the lateral femoral epicondyle. Whenever you move posterior, the plate lateralizes on the distal block. As it lateralizes on the distal block, it comes off of the bone proximally. As you put screws proximally, it pushes the distal femur over. So, having an anatomic reduction, if possible, or near anatomic, and then using the plate as a neutralization and just laying it in place and putting screws into it can be really helpful. And I 100% agree with Derek and John on the value of lag screws in geriatric bone. It's not great. That's one of the reasons I like to use a plate combined with the anti-glide positioning of it. You don't have to work. You don't have to depend on that near cortex to hold a 3.5 millimeter head. You can use the whole plate as a washer. So it's a little more durable, but still not very rewarding.
Yeah, I think that's a terrific tip. John, one more question on this case, maybe another if it pops up, but how do you feel about the overlap of the hip prosthesis? Is that enough? Is that what you typically do? You look any different when you're done here?
No, I think that's fine. If you need a good place, or if you're struggling to get fixation and you need a good opportunity, the lesser trochanter is a posterior structure, and that's a good place to dock into if you need to. But two widths above the tip of the stem, which I think is plenty. Two things I want to comment on. One, with these patients who have had total knee prosthesis in place, they get a lot of lateral and medial condylar kind of hypertrophy, and so that will actually push the plate or create even more of a deformity, especially if that plate sits a little bit more posterior, because they get, I don't know if they get stress shielding or whatever, but the condyles hypertrophy a little bit more proximally, which can affect implant placement. And then someone had a question about cerclage cables, and I think there is actually a role in these spiral oblique fractures. If you don't do an open reduction, I think there is a role for biologically responsible placement of cerclage cables, as long as they're placed directly onto the bone. And these can actually help with reduction, and then you can place your plate directly over them. I in general don't like cerclage cables for younger patients, but in these patients, I think they can be used, and I don't think there's anything wrong with them. You guys can fry me for saying that, but I think I think you can use them in a situation like this without a problem. It's all about rotation. It's all about just keying in that rotation. It's a very unstable fracture pattern. That's the challenge that I have with using cerclage cables, that it's just a tremendously unstable pattern.
Yeah, I think they're useful to help maintain your reduction at times, but I think they definitely have a place, depending on where it is. And I think that the other comment on the remodeling distally is you sometimes get the same remodeling proximally around the femur. It can fall on have some varus remodeling around the hip stem, which makes it challenging. But the lateral view is a great, way to see how much room you have around that stem to get, if you're going to have trouble getting your fixation proximally. So, but I think this is a nice construct. Before we move on, one question. Go ahead. Sorry, Matt.
Sorry, one other question. Would anybody nail this? I mean,
yeah, I wanted to bring that up. Who's nailing this? John, you nailing this?
Not off the bat. I've combined implants before, though. Maybe not with this type of hip stem, but with narrow hip stems, I've modified some implants to get a nail and the tip of a hip stem to kind of a butt, and then use something kind of submuscularly just to bridge that area laterally. So I have combined implants, but I think I'd like this. I would use this if I had this fracture come in tomorrow. I would do something very similar to what was done.
John, I think I lost you for a second there. You still there?
Yep. Can you hear me?
No? Yeah, I got you. You're good. Yeah, I think I think what you bring up a good point, though. If you do think about nailing this, is you have to do something to address the stress riser between the two, especially in osteoporotic bone, right? So I think that's important. All right, I'm going to move on to the next case. Any other questions, Matt or John, that we should address before we move on?
I think you're good.
All right, cool. All right, case number 3. All right, so this is a geriatric distal femur fracture with this bony injury. And this is some specific cuts of CT and then a 3D recon imaging, reconstructed image of the distal femur. Matt, when you see this, what are you thinking off the top of your head right away?
How old by the way? You said geriatric, like how old?
In the probably, I think, late 70s, early 80s. I can't remember exactly.
Isolated injury?
Yeah. Old tibial nail.
Yeah. So, I mean, initially I'm thinking, you need to get an anatomic reduction. There's some articular injury to this that looks fairly straightforward. A little bit of a trochlear impaction injury, which, at that age, is plus minus how much you have to really consider it. But I'm going to want to see the joint for the procedure. So the first thing I'm thinking is OR setup. I tend to do all my femurs on an OSI flat top because it's just easier for me. I'm comfortable with the setup. I'm sure the two of you do a very similar setup. So OSI flat top, leg bumped up so I can get x-rays. I would probably treat this with a lateral parapatellar arthrotomy from a surgical approach standpoint, just so I can see the joint, I can see that reduction, and I just follow standard AO principles from the outset. So lag across the joint, get the articular block back together, and then try to deal with the complex metaphyseal nature of this. Classically, this would be treated with an indirect reduction in a lateral bridge plate construct, which I think is very appropriate. I think, the concept of dual implants, which is what we're talking about tonight, was really, started with Jeff Mast, and it was to kind of supplement your medial cortex, which is the problem with this particular injury. You're probably going to get a reasonable read. You can even shorten it a little bit laterally to get some compression if you really want it, but the medial side is the problem. So I would really consider an intramedullary fixation on this, not necessarily because I think you need it from an overall, fracture healing and construct standpoint. I think it's gonna increase the longevity of your construct, and that medial side may take a while to heal.
Yeah, I think
I would not go medial on this. I don't think I'd put a medial plate on this.
Yeah, I think that ties in really nicely to our next polling question. So let's launch that, and then we can further the discussion a little bit. So does this intra-articular split and this kind of fracture pattern influence your treatment at all? So because of that, more likely to plate, more likely to nail, more likely to do some kind of combination fixation, or more likely to do an arthroplasty? The person is in late 70s, early 80s.
So while people will probably get those results here in a second, well, never mind. I'll hold off till you ask me.
All right, so 50% are more likely to plate this, and then probably next common would be dual plates, but they're all about the same: dual plate, nail, and small percentage arthroplasty. Really low likelihood, 4% only to nail only. So, Matt, why don't you tell us what you're going to say or ask? I guess.
So I think it's a tough question to ask, and maybe the one that we're all thinking, but maybe the wrong question, because just because you have an articular injury, you still have to treat the metaphyseal issue. And while they're not mutually exclusive, you can think about them as separate injuries, right? There's no reason you can't get an articular reduction on the articular injury and still treat the metaphysis differently. If that fracture was 10 centimeters up, we'd be having a very different conversation about it. So, I mean, that's what I try to kind of teach to our residents and fellows, at least to some extent. And I know you guys probably share that mentality at least a little bit.
I got to tell you, so the first things I think about with this are, one, the next operation, if and when this fails, or if it goes on to arthritis, which means that I'm probably going to utilize something that revolves around an anterior midline incision. And I'll tell you that I think my answer for this, or not my answer, but my treatment of choice now is different than it was probably about, 4 or 5 years ago with regard to what implants.
All right, so John, why don't you talk us through this? This is yours. So why don't you give us a little thought process behind, is this something you would do now or something that you did 5 years ago?
Is it really mine?
Yeah.
Okay. Fantastic. Well, this is exactly what I probably would not have done this. Sorry. This is exactly what I would, what I would do now is I'd use an intramedullary device for this. And so, restoration of the articular block, get the articular reduction, utilizing independent screws and then placing an intramedullary nail, for that area of metaphyseal comminution. And I think that I've been very frustrated sometimes with trying to dial in metaphyseal reads with a plate. I know, historically the plate group was supposed to always have the more predictable alignment, but I really like an intramedullary nail, and you can either supplement that with a plate if you feel the need to, or use cortical replacing screws in this injury with this type of poor bone in the more proximal segment to support your fixation. And so this is, I can't remember, honestly, obviously because I didn't remember that it was my case, utilizing, likely utilize some sort of anterior skin incision that could be utilized for a later arthroplasty. And then that also makes removal of the implant easier, to subsequent stage. So.
Yeah, I think you bring up a lot of good points. I think thinking about the next surgery, obviously you don't always want to, presume our fixation constructs are going to fail, but I think that's important to keep that in the back of your mind. But, I think, an intramedullary device for this is a reasonable choice, given all the things that you and Matt talked about with the metaphyseal comminution, doing a nice job getting an anatomic reduction of your articular surface and then treating that metaphysis with an intramedullary implant. What would you do now for their weight bearing status afterwards? And Matt, I would ask you the same question.
So now I do remember this gentleman. So I let this guy do flat foot weight bearing for 6 weeks, and then allowed him to transition to weight bearing as tolerated. The one thing I would probably do differently now is I would take, there's a nice, I believe it's Hassan Mir's group that talked about kind of what they call the bell clapper effect of utilizing cortical replacing screws in short segment fixation in these osteoporotic patients. And we commonly think about utilizing cortical replacing screws, adjacent to the distal portion of the nail in the short segment. But in this specific injury with this bone, if you're utilizing those screws, putting them actually in the proximal segment to decrease that, the toggling of the windshield wipering effect can be very helpful. So I actually, just above that metaphyseal comminution, would have put some A to P screws, and you can do the exact same thing distally, to control your entry point. There's a question about flexion extension of the articular block, and Drew, I would just say that I think the most important thing here is just making sure that your start point and your initial trajectory with your guide wire is spot on. And I think that's, we'll take a tremendous amount of time making sure that the entry portal and the path in the distal segment is righteous, because these can very easily go into extension as well. Less commonly they go into significant flexion, but oftentimes extension. You want to make sure you have those condyles tucked down at about 90 degrees.
Yeah, I think the use of the cortical replacing screws or something of that nature to help control the nail as well, I think is useful, even if you put it in after your nail fixation to narrow that for you.
Would anybody consider there's a
Matt,
question about
John?
meat bone on the medial side?
Yeah, meat bone on the medial side. Any thought about that?
So I've done it for a variety of reasons. You can actually get fairly proximal before the vessels are kind of in your surgical field. And fortunately, at least in central Pennsylvania, oftentimes you can see the vessels on x-ray, so you know exactly where they are. But there's some vascular studies out there that kind of talk about exactly where they are, and they're 30 to 40 centimeters above the medial femoral condyle, depending on the size of the patient. So it is an option. I will say the one thing I've run into with medial plating is people do not like a plate over their medial distal femoral condyle. I tend to try to put it above that, because if you get down that low, it really bothers people.
Yeah, agreed. The medial side can be a little challenging from a soft tissue perspective in general. All All right, as let's for time's sake, let's move on to case 4. So this is another gentleman. Brian is mid 80s, fall, and so comes with these injuries. So Matt or John, what are your thoughts about this? Matt, we'll start with you. What are you thinking?
Is there an articular injury of the distal block?
No.
And obviously, I'm assuming the previous subtroch, it looks like some type of intertroch, subtroch extension's already healed.
Looks that way, yeah.
Yeah. So, and how much surgery can they tolerate, I guess would be the next question.
I don't know. It's a geriatric patient, so who knows?
Right. So the reason I ask is, to me, the big question is, are you going to remove this implant or not? I think in an ideal world for a geriatric patient with what's essentially a distal third extra-articular femoral shaft fracture, I would want to get intramedullary fixation with multiple vectors of fixation in the distal block. So, implant choice is a factor there, but I'd want to prevent a stress riser while at the same time protecting the proximal femur. The two different options to do that would be to retrograde nail with the implant that's already there, but you have a very short isthmic segment, you have a very short shaft segment. So the length of the implants becomes a limiting factor. I think in an ideal world, I would remove the proximal implant, put in a DHS, and retrograde nail, similar to if this was a segmental femur fracture in a younger patient. If they're not able to tolerate that, I would probably go with some form of laterally based plate distally versus, I trained on this. It's not something I buy into completely, but if you really want to have intramedullary augmentation, a fibular strut or a medial endosteal plate could be helpful, but then you're going to have to overlap the existing intramedullary implant proximally.
Yeah, before I ask John, let's just roll this polling question real quick, because I think you brought up all those points. So what does that hip implant do to you? Like, how does that change your thought process of fixing this? Because I think, Matt, you bring up a lot of really good points and thoughts, and I think a lot of it has to do as well as with what the patient can tolerate, right? And what you're able to do to them.
Matt was just looking for an opportunity to throw fibular strut in there somewhere. Just looking for the right case.
That's right. Let's see what I got. So most 59%, almost 60% more likely to plate here. 20% do some kind of nail and plate combination. So jump to the floor shots here. So John, this is also yours. Walk us through your thought process here, because it looks like you didn't do anything to the proximal implants and chose a dual fixation construct.
Yeah. So for me, I don't want to mess around in an older patient with horrible bone quality in terms of, removing implants, putting new implants in. I think that, my tolerance is probably at, just removing a interlocking bolt maybe, or one or two. With bone this cavernous, usually have opportunities for fixation around. And so utilizing a submuscularly placed plate through a limited incision, respecting most of the biology on the all the biology really around the fracture site, and then just using indirect reduction techniques to line things up. And then once I had fixation distally, and you can see the kind of the sequence here of making sure that I had fixation distally outside of the path of where my intramedullary nail would go, unicortical fixation proximally to kind of keep everything lined up. And then it's just length alignment rotation and giving something that this patient can walk on right away. And so once the plate is on and things are kind of dialed in, and then standard nailing technique, which is essentially at this point just sawbones, and then trying to figure out length of the nail, and then placing nail, and then just filling in as much as I can. So utilizing a nail that has multiple options for fixation. And this is where you just have to know your implant supplier to be able to utilize as many locking bolts, around the two implants. So.
Yeah, I think that's great. Thoughts about, why plate first versus nail first? Do you have a strong opinion? Do you let the fracture dictate that for you? How do you choose?
No, I don't think it makes it, honestly, it makes absolutely no difference whatsoever. It has been described both ways, and I think this is just preference. You just have to, whatever you want to do is completely fine. And so in this one, I actually utilized the challenge with this one was the nail that I wanted to use was going to be too long, and I wanted to try to abut the two implants. And I did okay, but had a little bit of difficulty. I would have, in the ideal world, I would have actually been able to kind of dock the distal part of the nail from approximately into the nail, which was coming from below. So one of the things that I do want to mention, and maybe not necessarily in this one, and this is not published currently, but the original description of this technique says utilize the smallest diameter nail possible in order to maximize opportunities for fixation. But the actual nail diameter does make a difference here with regard to the biomechanical strength of nail plate construct. So I've actually gone to using not just an 8 or 9 millimeter nail reflexively, but utilizing a large nail when possible. So you can do nail first or plate first. I don't think it really matters. It's just trying to get creative with maximizing fixation in the distal segment.
Yeah, I agree with all those comments. I think it's just being thoughtful about it too, right, John? Understanding you made a very good comment when you played it. You made sure that your screws were out of the way of your intramedullary fixation that you were planning. So I think preoperative planning is critical to success for this as well. Matt, any additional thoughts about that?
No, I think this is great. And the only other thing I'll say is not everybody has access to a number of different implants. We're fortunate. We're all fortunate to work at big centers where getting something in usually isn't a great thing. But if you ever need to create interlocking holes in a titanium nail, a carbide drill bit works really well. And I've had to do it a number of times. You can also shorten nails if you need to. So if this is what you're really trying to get, you don't have the best implant, you can usually make one in a pretty short period of time.
That's a good technical trick. Thought real quick before we move on, one of the questions I noticed, and maybe it's too much of a Pandora's box for this one, but is this a reason to use long nails for your hip fractures?
Yes and no. I mean, statistically speaking, the fracture rate below a nail is 4%, whether it's short or long. I tend to use long nails that go really long and try to pop them into the near the trochlea as much as possible. I don't know, John, what do you think?
Yeah, I mean, I've seen people fracture below long nails as well, and so I don't know. My practice actually is changed. I've started to use more to use shorter nails, honestly, for speed and for blood loss. There is something to be said for reaming the canal, especially we just finished up with a patient, 98-year-old intertroch, and for me, with multiple medical comorbidities, the goal of just getting stable fixation and kind of off the table as soon as possible. I've started to use more short nails probably in the last 2 years than before. So
yeah, I think it's one of those things. It's whichever complication you want to deal with. So all right, good. So let's go on to this case. So 81-year-old fall, this supracondylar distal femur above a total knee. John, what are your thoughts about this when you see it?
Yeah, so same thing. I think we're seeing some reoccurring themes here. I just want to figure out whatever I can do that's going to get this patient to weight bear, and then I want to make sure I know exactly what the situation is with that knee. That looks like a posterior stabilized knee, which has a box, and So it means I'm going to a plate, either single plate or dual plates. You can 100% find an access point, create an access point in a posterior stabilized knee, but I don't like doing it. I don't like having to, look at the poly as it comes out with my entry reamer. When I put the entry reamer into the distal segment, and I'm not usually equipped to start replacing polys if need be or something like that. So this is going to be a plate for me. And 81-year-old, I'm going to be dual plating this.
Nice. So this next polling question, because I think you bring up a good point. So do you bother even thinking about the stability of this total knee component? And if you do, how do you do it? If you don't, maybe that's your point, John, you're going to stay away from it.
The way I judge the stability of the distal component is like I do for proximal periprosthetics. I kind of look at it and touch it, and if it doesn't move, then it's stable enough. No, because I mean the bottom line is that if you say, okay, well, it's unstable, or I mean, unless it's truly like grossly falling out, if you can get this patient to somewhat solidify the metaphyseal region, a revision stemmed knee at some point later is much better than a distal femoral replacement or something similar. So if you get their metaphyseal area to heal and they have pain from a loose component, that's at least from what my arthroplasty colleagues have told me, that's and we use the same approach in the hip. If you can get the metaphyseal area to heal, or the bone around the fracture to at least heal, then a revision is much easier than going to some sort of mega prosthesis.
Yeah, I think you bring up a lot of good points, and it sounds like some people aren't looking at it at all, and some people are doing the similar things, Sestorian surgery or preoperatively. So it's kind of across the bag. But I think it depends on if you're going to do anything to it or not, right? And I think it was Bill Ritchie's study looked at this and showed that like less than 1% of these are loose, right? That there's this good decent bone to get fixation. So this was yours, John, and it looks like you did a dual plate construct for the reasons that you were discussing. Matt, how would your fixation strategy differ in this? What would you do differently?
Yeah, I would probably try hard to use an intramedullary implant, and while I agree with John, I think this is probably a knee, although it has a box. A lot of the boxes are open. It does force your starting point more posteriorly. There are ways to correct for that and try to adjust for that. And some of the newer implants have a more aggressive bend. As far as assessing the stability of the implant, I just like to make a plug for anybody out there who's, and if you're one of them, who's comfortable with revision arthroplasty and trauma at the same time. I think having somebody like that manage these injuries can be really helpful because they can make those decisions. To John's point, if I'm in there, I'm fixing it for the most part. The decision's already been made, and I look at it, maybe poke it a little bit, but don't do much more. So I think I'd have a CT on this ahead of time. I'd see if the box is open. I'd see where the entry point is, and if a nail's reasonable, the way I try to avoid the poly issue is I use an 8mm terminally fluted reamer, and it's usually end cutting, so it's a little bit easier to get through the cement mantle, and you don't have flutes coming all the way down the opening reamer that chew up the poly because you're inside of the box when you do it. And then I use flexible reamers to ream up in the distal block. But I think this is perfect, and for me, final fixation would really depend on the CAT scan and what I had to look at. But in an 80-plus-year-old, I'd try to not only get intramedullary fixation, but I'd try to put my distal interlocking screws right up against the implant.
Derek, can you go back one image? And this is maybe two images. Sorry. We didn't talk a ton about the reduction. I think we're maybe at a little bit of higher level talk here, but you have no idea how these knees get put in, whether they're put in varus or valgus. And I really encourage people to utilize either a long guide rod, some sort of marking on their table, or a tension bovie cord in order to check alignment, because I think one of the that's what we're doing here on the right hand side. And I'm just making sure that my axis from the center of the femoral head, down through the knee, down to the center portion of the tibial plafond is somewhat centered over the knee. Because if you go to the next, or you go to the final images, that doesn't necessarily look right. It looks at that fixation is in a lot of is in almost a tremendous amount of valgus, and the rotation affects that. A cone down image from your image intensifier affects your ability to judge that. So use some sort of external guide to try to make sure you're aligning these correctly. Especially if you don't have a cortical read or a good opportunity for to judge alignment.
Yeah, I think that's a critical point, John. I think, when dealing with periprosthetic fractures, like you don't know, there's something a little bit different about it, and it depends a lot about how that knee was put in. So one of the questions was, I think you touched on a little bit, but what plate do you use medially?
So most of the time I'm just using some sort of, I think Matt had showed a nice image of one with a 3.5 millimeter small fragment reconstruction plate. This is just a bent 2.5 millimeter small fragment plate. You can use a flipped proximal humerus plate. You can flip a proximal tibia plate. The challenge here is that the medial slope, the trapezoidal medial side is it's about 25 degrees off the true AP plane. So you have to figure out something that kind of sits almost anterior medial. But in the metaphysis, you can usually just bend some sort of small fragment plate. The biomechanical studies that have been done utilize a fixation construct very similar to this, with just a small fragment implant on the medial side. But the goal here is immediate weight bearing. So this patient was allowed to weight bear as tolerated immediate after surgery. And this is, I can't remember, he's like 3 months out from her injury.
Yeah, I think they were a few months out for sure. Nice case. All right, for the sake of time, I'm going to skip to our case 7, and then we'll go from there if that's okay with everybody. All right, so this is 67-year-old female with this injury, not too dissimilar to the previous one, distal femur periprosthetic fracture. Kind of go just a polling question and then kind of go down the rabbit hole that this one takes us, and then see where we go. John and Matt, I think we have a good understanding of where your mind goes with these. So we'll save some of the questions for how this one plays out a little bit. No hip, nothing above, by the way. So kind of across the board. So lateral plate, 70 dual plate, 30% IM nail, nail plate, 30%, 9% distal femoral replacement. So this is how this lady was managed. So she was treated with an intramedullary nail. You can see this kind of deformity translation on the lateral here, and this floor shot with the nail going up. Matt, when you see that, what do you do?
I pull the nail and I put a blocking screw in. I'm really quick. So to me, that lateral looks like the nail's in an appropriate position in the distal block, and it's too posterior in the proximal segment. And to John's point earlier, that's that bell clapper effect that has been written up. So the nail comes out, a posterior blocking screw goes in. I'll also use blocking wires because I'm not the best at putting my screws in the right place. So I'll put something in that can easily be removed. But if you're gonna nail relatively distal femur, some people call it extreme nailing, but if you're gonna do it, I think you have to be really comfortable with blocking or Pollard screws.
I would agree. John, what about you? Similar thought process? Pull the nail, cortical replacement screw?
Yeah, proximal, something in the posterior aspect of the proximal segment to drive that, drive the shaft down posteriorly and then replace the nail. And I like that. I like the technique that Matt talked about. Utilize a stiff wire first, and see what it does. And then if you like what it does, then you can always replace it with a screw. But instead of making a bunch of 5 millimeter Swiss cheese holes around the femur, I think you at a minimum 2.4 millimeter or 2.8 millimeter Kirschner wire can be strong enough to affect change.
Great. So that's what was done in this case. And this is kind of their end alignment. And so any thoughts about reduction, implant choice, things you may or may not be concerned about, or everything looks good? John or Matt?
I mean, I think the alignment looks great, right? I mean, it'd really be really hard to argue with the coronal and sagittal plane alignment. That kind of anterior medial to posterior lateral locking screw, whether that interlock, whether that goes through the fracture or not, it's a little bit hard to say. But overall, I mean, that looks pretty nice.
John,
Yeah, I
any
mean,
other
you just
thoughts?
this is one of the ones where you just have to, know your implants and know where the interlocking bolts are going to go, and you may have to measure that with preoperative imaging, or just know exactly how they're going to sit. That some of them are oblique, some of them are at angles. Just making sure you get multiple points of fixation distally. But this looks great.
Derek, is she missing bone anteriorly, or is that just a fragment maybe it's actually intramedullary at this point based on?
I think it's there. I think it's just missed. I think it's in the wrong spot. Maybe intramedullary. So she does okay, disappears for a few years, and then she comes back about two plus years out with this.
How old is she?
69.
Otherwise, I mean, she looks like a touch fluffy, but otherwise relatively normal functioning. I mean, like not normal functioning, but
yeah.
active.
She was ambulating with I think a cane, and then felt a crack and a pop. Wasn't able to bear weight acutely. So what are your thoughts now? One of the things I noticed is that obviously it broke at the interlocking screw, kind of right where the fracture was when the final construct was done. And I don't know if that's a weak spot in the nail, stress riser on the nail, and maybe doomed to do that. Or it's that typical race. But so what are we thinking now, Matt? What do you do now?
I mean, it's a uniplanar non-union by the looks of it. I mean, I do typical non-union workup, which I'm sure you did, get a CT. Everything comes out. Obviously, the proximal nail is going to be challenging to remove because the distal segment's going to come out. I think we've all probably been in that situation at one point or another. Assuming you get everything out without any issues, simple fracture non-union in essentially any bone to me needs compressed, and the best way to compress a distal femur is a blade plate. In my experience, in my hands. So take it down, non-union takedown, clamp it, and try to compress it with a blade. Although it's a little bit of it's a short oblique, but it's oblique enough that you have to worry about a shear when you do it.
How about you, John? What are your thoughts?
Yeah, I was thinking blade. This is I think you have enough opportunity for compression here. And if you really needed to, you could, do something on the medial side, but take it down. You could even optimize the surface area in which you're going to compress, and then squeeze it, because taking converting this to either a distal, and the reason I was asking about function is because it's either a distal, you either revise and go to the non-union, or you're thinking about like a distal femur, for it. So I think that's the discussion that you have with the patient, and based on their workup and kind of what they want to do and their desire for their function afterwards, you make that decision with the patient after, kind of giving them the options.
Yeah, I think that's a really good point as well. All good options. Discussed with her and thought giving her a chance at revising, repairing a non-union was the right move. So let's kind of run through just a couple of questions. Hopefully we'll answer in a chat. So, this is us taking the nail out. So a nice trick. I'd have to give Dan Horowitz credit for this. He mentioned it a couple months ago now, I guess, on a fracture night. But this is a 5-0 self-drilling, self-tapping Chance pin placed into the residual nail. And you can see it gets it incarcerates, and it gets nice purchase and able to take the nail out. Obviously, there's some broken screws left behind. One of the things that you guys had mentioned earlier, just talking about the knee and what they do with the knee and what happens to the poly. Sometimes this is a posterior stabilized knee. So this is when we did the arthrotomy, this is what we found. So who knows when this happened, but this lady had, her post was broken off. So, just one of those thought processes to, if you're going to do this, to have either the stuff around or the ability to change things out if you need to, which, we asked for in this case. And then I decided to treat this actually with a dual construct, a retrograde nail followed by a laterally based plate. This is kind of the sequence of which we did it with the nail and then plate, and then kind of linking the construct distally, and then I acutely grafted it as well, and put a screw across the neck to protect it from where we took the nail out earlier. So thoughts, John and Matt? Obviously it seems like you guys would have done something a little bit different, but
Yeah, no, I mean, I like it if it works.
I do too. We'll see. Yet to be determined, right? Yet to be determined.
No, I think it's really nice. You can, the nice thing about this is that you can let her immediately weight bear on this, and it looks like the AP. It looks like the only gap that you may potentially have is just that posterior area.
Yeah, right there.
And did you graft with autograft, or what did you graft with? They're just
no. I used some remings, and I also used some off the shelf DBM type stuff. Okay. Yeah.
Cool.
Guys, there have been a couple questions in the chat for these geriatric distal femurs about acute autograft, allograft, BMP. Are you guys using anything acutely? If so, why? If not, why?
I don't use a ton of stuff off the shelf. If I want to use it, if I use something, I'll use remings or iliac crest or posterior crest or something like that. If I need to bulk up what I have, then I'll use crushed cancellous or DBX or something like that. But that's about it. Nothing that really has like cells in it or anything like that.
Yeah, I don't usually acutely bone graft these at the time, except for non-union stuff. But in the acute setting, I have not been doing that.
So I don't either. But we're talking about non-union rates in the 20 to 30%. Maybe it's a consideration. It sounds like some people in the audience are doing it. I never have. I only do it in non-union settings, and it's almost always autograft. But it might be worth a consideration.
Yeah, the challenge with a non-union and a geriatric patient like this is you go to take bone from their canal or something like that, and it's
not great bone.
Right. Yeah, I mean you get a bunch of wash. That's about it.
I had a distal femoral non-union in an 80-year-old recently that I went to the pelvis and got like 15 cc's of bone graft. It was tragic, actually.
Oh, it's heartbreaking.
Yeah.
All right. Well, I just want to run through just for time's sakes, and then we'll open up to any other questions. Just kind of the technique. I'm going to save some of the video stuff, but I think, you heard a little bit about some different thought processes, whether to nail it first, plate it first, or whatever. But I do think having a systematic way to think about it. This was published in JOT back in 2019, Dr. Liberace and Dr. Yoon out of up in Northern Jersey. But I think it's just, it's a thought process behind it. And I think just like anything else, the thought process can be modified and adapted and adopted to the situation that's presented to you. But they describe kind of going about it where, obviously, your approach and reduction and then retrograde nail followed by your plate. I personally have always thought about this as plating it just like, plate everything else, plate balance, and you pin it in place, and then you lag with non-locking screws to compress your plate to bone, and then you kind of lock or finish your construct however you want to. There's discussion about linking the system versus not linking the system, and probably could debate on that for a long time, but there's not good literature on that. So, but this is just kind of some of the thought process. This is just an 82-year-old with this distal femoral fracture that decided to treat with a nail plate combination. So nailing is pretty much the same. The one thing I will say is that John kind of brought it up is using a a nail that has multiplanar fixation distally. And when you get your locking distally, to put kind of those oblique screws in, so it would be out of the way of your plate. So you get kind of this provisional fixation with your nail. As far as the size of the nail, I agree with John 100%. You know, the literature, these techniques say using smaller diameter nails to get bicortical screw fixation around. But again, and a lot of times in these geriatric fractures, the intramedullary canal is plenty big enough to put a larger diameter nail and still get fixation around it. So again, just thinking about off-axis fixation in your nail when you're doing this, right? And so once you again, starting point, open it up, and then you get your provisional reduction for, you know, with your nail, there is going to still be flexibility around this, and then get your locking fixation. You know, in this case specifically, I put all three of these distal interlockings in, and then when I decided to nail plate it, I took this lateral medial interlocking screw out, and I'll show you why in a second. So then at that point, we put our plate, you know, get our plate balanced. I think a good way to do this, if you do want to link the system, completely, that's kind of up to you, but I do that. You use your jig for your nail, and you use the guide through the nail, through the jig through the nail, through your plate. Get your plate balanced distally that way, and then you focus on getting your plate balance proximally, again, to assure that you can get your optimal fixation that you wish for the construct. So that's a nice way if you do want to link it, to assure that it will be linked. And then you can use, get screws around that nail distally. And if you balance your plate proximally, appropriate screw fixation proximally. And then this is kind of seeing that again, plate balance. You can see I took out that distal screw, and now we're measuring that, but it's through the jig, through the nail, to make sure that's going to go through both the plate and the nail, if that's what you so desire. And then here, just putting, again, your fixation, your either interlocking screw or non-locking screw through that part of the nail, which goes through the plate, through the nail, to link those two constructs, and then coming proximally once that screw goes in, and putting your non-locking screw around the proximal aspect of the nail to compress the plate, the bone. And then once that's complete, then you kind of go back and you've kind of finished your construct. Here you can see putting non-locking screws in to dial in your coronal, and then also your sagittal balance. And then lastly, putting, you know, screws kind of around the nail distally, and then once you're happy with your density of fixation distally, coming proximally and getting the rest of your fixation around the nail. And then, you know, final floral constructs with the final constructs there. So I just want to kind of share that technique. I know I went through that kind of quickly, but there is, this will be recorded, and that video will be made available. So just take some take-home messages. I do want to get John and Matt's final inputs on this as well, and then any questions out there. But, you know, fracture fixation principles remain the same regardless of the fixation construct. So remember, articular injuries, anatomic reduction, absolute stability, restoring and maintaining the length, alignment, and rotation of the femur. You know, nail plate or plate nail technique can be implemented to improve your fixation strength. Remember, the density of fixation distally is significantly increased, and has been shown to broaden and kind of unify the stress load across that distal femur. Dual implant constructs are also very beneficial, especially in periprosthetic fractures in that short segment. You know, John did a really nice biomechanical study showing that the dual implant constructs from a dual plate perspective is an extremely stable construct. And then combined constructs, and just in general, just allows for the potential of earlier weight bearing. And I think, you know, as we see more and more of these in the geriatric population, that is going to be critically important. And so with that, I would like to open up to Matt and John for any, you know, any other take-home messages, any comments or thoughts, and then any questions that we might not have gotten to or we could get to now.
Just say thanks for the opportunity. And you know, everybody thinks lateral plating is standard and ideal, and I agree with that in a lot of ways. But you know, a non-union rate of 20% or more is unacceptable for a relatively common injury, and I don't think any of us would claim to have the solution to this problem, but I think some of the stuff presented here are you know, their potential. So just keep trying different things, and obviously within the realm of what's considered reasonable, and follow your standard techniques. But we can all do better with these injuries, and hopefully we will in the next 25, 30 years.
Great.
Yeah, thanks again. Appreciate the opportunity. You know, I think the one thing to take home is that there still remains a biologic impact of going to the medial side, and so I think you have to have a reason to do it, and whether that's improving, you know, as a means to improve stability, or you know, achieve a better reduction. You know, those are kind of the two reasons that I will go to the medial side to actually place a surface implant. I like the minimally invasive techniques that can be utilized for nail plate fixation, and you know, while it may not be, you know, biomechanically as strong as dual plates, you know, again, I think preserve a lot of the soft tissue attachments to the, you know, the anterior and medial side by utilizing a nail plate combination. But don't forget, nails alone and plates alone still function very effectively, and when placed correctly, can, you know, do just a fantastic job as well. So you really have to have a kind of a reason to be, you know, jumping to the combined implant techniques that we've shown here. I don't want anyone to take away from this that, you know, any of us are utilizing dual plates or plate nails for every single distal femur that we get. There's a reason for that, you know, and as long as you're kind of justifying it, and you know, improving what could otherwise be achieved by a single implant, then good to go.
I couldn't agree more, John. Just for those who stay on after us, there will be a post-course survey to get CME credit. Mark, I think hopefully we'll be able to send that out otherwise as well. But yeah, no, I agree. I see there's a couple other questions, but for sake of time, I'm sorry, we won't quite get to them. I think we try to answer the majority of them and talked about most of them during this session. So I'd like to thank the AO for putting this on. And I'd really like to thank Matt and John for, number one, their cases and their input, and just being incredible individuals and awesome outside the box thinkers with me. So thank you.